What we're going to work on today is on narcotics. One of the things about narcotics that's really important is that there's two medications that we use almost universally in every case. We have our volatile anesthetics for general anesthesia, and then to supplement the actions of the volatile anesthetics, we have to add the opiates. So you really have to have a fairly good understanding. Now, what we're going to do a little bit differently on this lecture is that I'm going to throw out pretty much all the stuff that we don't use. So there's some that you'll read in the book that they'll mention, but they're so superficial that it's pretty much useless, because guess what? You don't ever use it. So the stuff we're going to concentrate on is really the stuff that we use every day. And then you got to sort of decide how to use it properly, when should you use it, and what are the side effects of many of these medications. So what we're going to do is I'm going to go over pain pathways a little bit. I'm going to go over opiate receptors, and then mechanisms of action, then the actual clinical uses of narcotics, anesthetic indications, orders of potency, onset of action, duration will be discussed in all the agents. The mechanisms of neuroactual opiate anesthesia will be also discussed the next hour. Side effects, and we'll try to compare absorption, distribution, and different forms of metabolism by narcotics, which most of them are similar to each other, but there's some slight differences, and you need to understand those. And then the major side effects of the agonist. And then we'll talk about, at the end of the last hour, about the antagonist, how you reverse some of these effects. Now remember, when we talked about pain, which we did this in the first semester briefly, but we keep talking about it on and off, it's basically information that's arriving through some form of nociceptor. If it's a somatic sensor, it's something in the skin that senses either pain, it might be a mechanical receptor, or it actually has a chemical receptor, like an inflammatory mediated response. That information comes up as an afferent fiber, which we call partly a peripheral nerve, goes up to the dorsal root ganglia, and eventually binds to the substantia gelatinosa, which is zone 2 of the dorsal column. And then it sends interneurons over here via secondary pathways, goes ascending, goes to the thalamus, where then it distributes that to the cortex of the brain, which is usually the postcentral gyrus. Okay? So that's all part of things that we've discussed before. What we didn't talk about too much is that there are gates in this. And the gates that modulate this system are opiate receptors. So opiate receptors are things that are naturally occurring in your body. They're there to shut down the pain fibers. So in case you need to move, even though you're hurt, you can. So there is a purpose for this modulation system of shutting it down. Basically, uncontrolled afferent input can be totally crippling, and organisms must be able to shut down this system. Basically does this by neuromodulation using opiate receptors. Now, the outflow to this as well is that as a consequence of this interneuron interconnection, which is not shown here, is that it goes to the lateral, the anterior lateral portion over here, and that's where the sympathetics are at. So it's a reflex arc. When pain starts, you should expect that the reflex arc will initiate a sympathetic discharge. So you should expect to see, when somebody cuts you, that your heart rate goes up. That's the somatic pain. On the other hand, if it's a visceral pain, a deep pain, somebody cuts you really deep, then you actually may get into a vagal response. Okay, so as it becomes parasympathetically mediated, and you get intense bradycardia, and the person loses consciousness because of the heart rate dropping off. Not that it vasodilates you, just that you're just not having any cardiac output. I had somebody do that to me the other day. We were putting in a block, and in the middle of the block, the guy just said, "I'm not feeling well," and as soon as he looked at him, his heart rate went to 0. Okay? Now, what do you do in that situation? He's got oxygen already on him. You just support his airway, and he'll come right back. But the first thing they'll do is they'll seize. Okay? It's not seizures because of seizure activity. It's seizures because there's no blood flow to the brain. Okay? It goes away in a few seconds, and then the heart rate comes back up. Now, we got atropine. We were about to give it, and the heart rate already started back up, so it usually is very short. But it will cause, basically, you to go unconscious. Now, the opiate receptors are located in many different areas and in different densities, and there's actually different distributions to these opiate receptors. You can see here in the substantia gelatinosa, which is zone 2 of the spinal cord, is actually a fairly important element. We'll talk about what's called neuroactual anesthetics later on. This is the area that we're going to be really covering heavily. That's the areas that we're actually injecting the local anesthetics, the narcotics into the spine and the epidural space to knock out those opiate receptors. You can see that there's still opiate receptors all the way up the actual brainstem and even up into the thalamus, where you actually can neuromodulate the system down. Now, the kind of receptors that opiate receptors are mostly, it's that they're G-coupled proteins. Okay, so these are all G-coupled protein receptors. They can be broken down into two kinds of receptors by their location. They can either act presynaptically before the information is even transmitted from one neuron to the next, so they actually can neuromodulate and shut down the release of the neurotransmitter that causes pain, or they can act postsynaptically to inhibit the depolarization. The presynaptic opiate receptor activation inhibits the release of acetylcholine, norepinephrine, dopamine, serotonin, and substance P. If you bind the opiate receptors in the postsynaptic area, it causes a activation of this G-coupled protein, and it actually inhibits the action of adenocyclase. Adenocyclase, by being inhibited, inhibits the calcium channels and sodium channels in the cells, so it makes it more unlikely for the cell to fire. The other thing that it also does is it activates potassium channels. It opens them. If you open up a postsynaptic potassium channel, what's going to happen to that neuron? This potassium leaves, so it becomes more negative. So it hyperpolarizes that nerve, making it more difficult for it to hit threshold and to cause depolarization. So these mechanisms are put in place presynaptic and postsynaptically to basically neuromodulate your system down so you don't cause pain. Now, the presynaptic opiate receptors, which are here, okay, change the activity of adenocyclase in this because it's a G-coupled protein, and that basically affects the calcium uptake via the presynaptic membrane. What basically happens is that calcium can't come in during the normal depolarization, and as a consequence, if calcium can't come in, the vacuoles won't be released. So it basically neuromodulates you. The postsynaptic receptors, on the other hand, they also work on adenocyclase, but they also work on G-coupled proteins, and they enhance potassium channels, so it makes the cell hyperpolarized, and it also inhibits the formation of cyclic AMP, which then inhibits the formation of pKa, which is protein kinase A, which then shuts down the system. So it's a pretty beneficial system if you know how to use it to be able to shut down pain effectively. It really is more efficient if you can cause the opiate receptors to be activated before the pain is caused. So it's called preemptive analgesia. If you can actually bind to these opiate receptors ahead of time, before the pain is started, people would require less narcotics because you're basically inhibiting the pain pathway from firing. This is called the wind-up theory also. The wind-up theory states that when you give somebody pain, there's a reflex mechanism that basically re-enhances the signal to basically cause you to have more pain if you get stimulated again. It's a way of shutting you down quickly so you don't injure yourself more. The downside to it is that if you have surgical incision, there's nothing you can do. Nobody else can attack you, so why have to go through that suffering? So by adding that narcotic ahead of time, you inhibit that wind-up theory, and then the person tends to do better post-op. Now, we know this to be true because when we're doing neuroaxial anesthesia for, let's say, total knee replacements, it used to take us 3 to 5 days to get somebody out of the hospital. Now we actually inject Duromorph, which is morphine, which is preservative-free, into people's backs, and they can be discharged in 1.5 days, and they're comfortable. That's pretty impressive. They can actually go to PO pills on the day number 2, and they can actually go home. It used to be people would be screaming in pain for 3 to 4 days, and it would take them up to a week before you'd be able to get them out of the hospital. So these preemptive treatments are really very effective, and we're beginning to understand the physiology better of the actual opiate receptors. Now, the opiate receptors, there's different receptors in the sense of quality. They're able to bind to things differently. They have different affinities to certain narcotics, and they have different responses as well. The differences in responses is because some of them are presynaptic, others are postsynaptic. The other thing that makes it different is that they're in different locations. And what this is to show you is that there's the other different kinds of receptors. The mu and delta receptors can affect pre- and postsynaptic receptors. The kappa tends to be a presynaptic inhibitor. So there's different receptors that do different things. Now there's basically three types of opiate receptors that we tend to talk about. There's mu, delta, and kappa. And then mu is broken down into mu1 and mu2. Okay? The kappa receptors tend to be found in high concentrations in the spinal and responsible for supraspinal analgesia. And where you find this in very high concentrations is in lamina 2, which is called substantia gelatinosa. Now, mu1 receptors, when you stimulate them, when you bind a agonist ligand, okay, which in this case would be a narcotic or be an opiate that binds to mu1, it produces very significant analgesia. Okay, and it does it at both the supraspinal and spinal level. So it does it at the brain and the spinal level. It also causes euphoria. The nice thing about if you could selectively just bind a mu1 is that it would have a low abuse potential. People would, because it affects their eyes, it will cause them to have miosis, which means their pupils will get very small. They also, bad side effects, they get urinary retention, you can cause bradycardia, and you increase the risk of developing hypothermia. If you, on the other hand, bind to mu2, you produce spinal anesthesia, so really this is not affecting the brain, but these people develop physical dependence very quickly, in a matter of days. You may actually also, we think this is a receptor that will cause the person to basically stop breathing or go apneic, so it's responsible for hypoventilation. It's also responsible for nausea and vomiting, and it also inhibits gastric motility. The normal agonists for mu receptors are called endorphins. So the normal body peptides, these are neuropeptides, that bind to these mu receptors are called endorphins. What mimics the endorphins that's outside, which is a natural occurring opiate that's in plants, is morphine. So morphine, which has been discovered almost 3,000 years ago in the hills of Afghanistan and continues to be used, is a very potent opiate receptor for mu. And then we also have our synthetic opiates, also will bind this, as we'll show you a little later. An antagonist, to be effective, must be able to bind to mu receptors so it can reverse the hypoventilation effects of this drug. And Narcan, which is naloxone, naltrexone, and nalmefene are all agents that are responsible for antagonism. What I've got in this picture here, I'm sorry it came out kind of light here, is that the G-coupled protein receptor is a 5-protein site. Okay? Every single G-coupled protein is a 5-protein site. What makes it interesting is that the mu receptors have different protein affinities in it that allow for narcotics or opiates or endorphins to bind very selectively in this area. Okay? So not everything can bind to it, only certain kinds of peptides, and basically we've mimicked that by using morphine as a way of binding these sites. The next one is the delta receptors. Delta receptors do affect the brain as well as the spine. They do produce analgesia. They do also have significant antidepressant effects. They cause physical dependence very quickly, and they also cause ventilatory depression. They cause minimal constipation, but they do cause significant urinary retention. And may also be an important receptor to activate to basically prevent or act as what's called ischemic preconditioning. It modulates the mu receptors, it's basically thought, and not many delta selective agents are really available. We're still trying to figure out how to produce them adequately, which we just haven't done a good job of that. The agonists that we have naturally are the enkephalins. Enkephalins bind to delta receptors. The antagonists, again, all fit the same thing. The kappa receptors are the next side receptor. They provide both supraspinal and spinal anesthesia. They do give sedation, dysphoria, there's a little bit of a low abuse potential, which is kind of a nicer thing of this drug, meiosis and diuresis. Now, what kappa receptors, somebody try to produce a drug that's more kappa-like, okay? And that one is Demerol or meperidine. Pyridine is more like a kappa-like receptor. They thought that it had low abuse potential, but you give enough to somebody, guess what? They do have physical dependence on it after a while. It's not totally kappa receptor specific. So none of these drugs, unfortunately, have been being able to be found to be perfectly specific to one receptor. What basically does when you cause kappa receptor agonists, they inhibit the neurotransmitter release via N-calcium channels, which I showed you before. This tends to be presynaptic. It also has inhibitory effects on the mu receptors, so it's a cross-check. And it results in moderate analgesia, so high-intensity painful stimuli may actually overcome this kind of narcotic. And that's what you see with Demerol. Demerol only is really good for mild to very higher, moderate, severe pains, but it's not really for very severe pains. If you have to try to give people severe pains with meperidine, it won't cover it adequately. Now, the agonists that are naturally occurring in your body that bind to kappa receptors more selectively are called dynorphins, and the antagonists, of course, are the same. Now, at one time, sigma receptors, which is I sort of talk about it here, because I do talk about it briefly in the book, used to be put in the opiate receptor category, and they're really not. Okay, they're not blocked by naloxone, so therefore they're really not considered opiate receptors. Now, what makes sigma receptors interesting is that it can act as an enabler for what's called dissociative anesthesia. When you give people ketamine, you're basically binding to sigma receptors. So it gives these people no pain. So in that way, that's how they thought initially, well, it's an opiate receptor. If you bind to sigma receptors, you're going to cause the person to have no pain, so it's an opiate. But you can't reverse PCP or ketamine with Narcan. So it's not really an opiate receptor. Okay? But it does cause hallucinations, dysphoria, and cardiac stimulation. Now let's go on back to the opiate receptors. Their mechanism of action, opiates basically bind agonistically at stereospecific opiate receptors. They can either be pre- or postsynaptic in the central nervous system. That's what we call the supraspinal, which is the brainstem, and the spinal cord. It can also bind to peripheral tissues as well. It's been found. The activation of the endogenous, the opiate receptors are normally activated by endogenous peptide opiate receptor ligands, and this is what I expect you to know for your test. So if I ask you which one is responsible for binding to help receptors, that'd be keflins, and which one is responsible for kappa, which that'd be dynorphins. Now, there's some definitions you have to know. Narcotics basically are agents that we're giving that is going to cause stupor. That's what the Greek word means for narcotic. It describes the potent morphine-like analgesic effects and the production of possible physical dependence. So the Greeks even knew that people could be hooked up on our narcotics back in the actual Roman period. Opiates were used to basically describe the drug derived from either natural or synthetic means that bind to the opiate receptors. What's really unique about opiates is that you don't lose touch, you don't lose proprioception, and you don't lose consciousness. Some people will appear to be asleep. If you give them enough narcotic, they appear to be asleep, but they're not. Okay? They're just really, really somewhere else, but they're still there. If you cause enough painful stimulus, or you tell them to open their eyes, they will all of a sudden open their eyes, and you'll be freaking. Because they appear to be dead. They won't breathe. Okay? They will not want anything to do with the world. And when you talk to people that are in that level of depth of the narcotic, okay, which I've met several people that have done this, okay, and you talk to them, they say they hear you, they just don't care. Okay? They hear your voice, and it feels like they're in the end of a tunnel, and they just don't want to pay attention to you. Okay? And I've told people, breathe, and you slap them on the chest, and then they'll go, okay. And then they stop breathing again, okay? And they'll do this, and they'll die. They will go hypoxic eventually and die But you can actually overcome it by enough stimulation and telling them to breathe, and they'll breathe. Okay? Now, one of the things you can do, and I teach this to you guys in clinical, is that the brain works somehow in some kind of weird fashion by seeing visual things sometimes. So if you tell them that you're seeing a bouncing ball, and I do this quite a bit when I do inhalation anesthesia, I tell the patient, think of watching a bouncing ball, and every time you see that ball bounce and hit the ground, I want you to breathe. And it's really strange. The person will start doing it. You say, bounce, ball, bounce, ball, bounce, ball. And the person, every time they hit the ball, they breathe. Okay, so you can keep them breathing. As soon as that idea goes out of their mind, which it takes a long time, they'll stop breathing. Okay, but then you can tell them, ball, bounce, and they'll start breathing again. It's very strange, but it works. So that's why I teach you it. Most opiate drugs are derived from opium. What is opium exactly? I'll show you that in a minute. There's ways of classifying opiates. You can do it by functional classification, like what they actually do. I think that's a fairly good classification. But also we'll go into the more specific ones, which are the chemical classifications. The opiate agonist basically binds to specific opioid receptors to elicit the specific response that you want. It basically is an ionized state for it to bind, because it's an anionic receptor location. And the actual ligands are levorotator forms, which means that they're rotated to the left. Okay? If they're rotated to the right, they're not effective. Now, naturally occurring opiates are all what? They're all levorotators. All of them. They're 100%. So when you have morphine from a plant, it is all levorotator. It's kind of strange. Now, if you try to produce morphine synthetically, which you can, what you'll end up happening is when you're finished is you'll end up having a batch that has 50% levorotator and 50%, which is R, which rotates to the right. The R one is totally ineffective. It does no good. Left one will be effective clinically. Okay, so the natural occurring medications are actually more specific for us, which is interesting. The plants themselves can actually make a stereospecific molecule based on their enzymes, and that's why they're all levorotators. If you use the next other classification is the opiate agonist antagonist. These are pretty much useless to us because we need to control severe forms of pain. The opiate agonist antagonists basically have a compound that's similar to Narcan, naloxone, and similar to a narcotic. So it has this combined effect, because that's what we call the ceiling effect. If you give enough of it, the person won't stop breathing, but they're only control the pain to moderate levels, because it's being reversed by the action of the same drug. So these people never get under good control for severe pain. So agonists and antagonists are pretty much useless to what we do clinically. We want potent agents. Okay? Now the benefit of using agonists and antagonists is you can send it to people home with this stuff, and you're basically not going to get respiratory depression and die from it. The downside to it is also the patient's not going to be comfortable. So, it's one of those weird balances. On the other hand, if you want to reverse these agents, you use what's called the antagonist. The antagonists bind to the same receptor site, basically competitively inhibit or push off the agonist. Okay? They bind to mu receptors, and they can reverse the opiate effects. Now, chemical classifications can also be used, and this is what I like to use. I think it makes more sense to me. You have your naturally occurring opiates, and then you have your synthetic and your semi-synthetics. Your natural occurring opiates, the number one class family is what's called the phenanthrines. Phenanthrines are what morphine is. Okay? It's also what thebaine is, what codeine, and hydromorphone. Hydromorphone is Dilaudid. Okay? So those are the major players of naturally occurring opiates. On the other hand, you have your semi-synthetics, which we almost never use, except for patients that are being using outside the hospital. So I'm not going to talk about too much about that. The synthetics, on the other hand, we do use quite a bit. The ones that we use almost exclusively in synthetics are what's called phenylpepridines. Okay? The phenylpepridines are really where you have to memorize. This is in red again. All these drugs, the original synthetic drug that was made was meperidine, and all the newer agents like fentanyl, sufentanil, alfentanil, remifentanil are byproducts, okay, or are cousins of meperidine. They're all phenylpepridines. Okay? Now this is your natural occurring opiates. They actually found this in San Diego the other day. I actually borrowed the picture from it. This is not Afghanistan. Somebody in San Diego decided to have a poppy field in the back of their yard. He told the cops it looked pretty. I tend to agree. It does look pretty. What they do is, this is the poppy itself, the poppy plant. These are the actual flowers that come off. They have very different colors. They have white, pink, and purple. What you see is that inside here, what the original name for opium, it means juice. You actually take the poppy itself and you cut into it, and you get this white liquid coming out of it. That white liquid is where the narcotic's at. Okay? It's an alkaloid. It's a very potent alkaloid. And that's what you actually get morphine from, codeine and dihydrocodeine from, and hydromorphone as well. The naturally occurring narcotics are this very complex three-dimensional structure which binds very nicely to opiate receptors. These agents tend to be more water-soluble, and that is a significant limitation. Water solubility means that it takes longer to get into the brain, but once it gets in the brain, it doesn't want to come out. Okay? So these agents tend to be longer acting, and they tend to be a smaller percentage of it actually gets into your brain. But when it does get to you, it then stays in there longer, and it can cause significant problems. So the initial poppy seed usually makes morphine. Morphine can be converted into hydromorphone, okay, and also codeine and hydrocodone. So this is the actual nice chemical structure formula to it. Now what you can see with these agents as you change them is we're going to change this 3 and 14 group and make these small little changes. It's going to make the molecule just change, and it's how it actually acts. Now let's talk about one agent first. Let's talk about the naturally occurring agent, which is morphine. Morphine has been around really not till the 1820s where it was synthesized. Before that, it was just sort of, the poppy was all compressed, and people would actually smoke the paste. Okay, they would put the paste into a smoking device and then inhale it. Okay, and that's how they actually would take the narcotics in the past. That's why it was like a gas that it used. It does absorb pretty well through the lungs. Morphine, though, is an IV agent, and also can be given IM. It's poorly, it really does not go into you orally very well. You can basically drink morphine all day long, and very little of it will get absorbed. Why? Because it's an alkaloid. Okay, alkaloids are basically bases. When it gets into your pH of your stomach, what happens to it? It breaks down almost immediately. So it doesn't really get into your system. Okay? Now, morphine basically will bind to all the opiate receptors, so it acts as an analgesic. It's a potent euphoric. It causes sedation. It diminishes the ability for people to concentrate. It does give them nausea. People feeling a body warmth. They get heaviness of their extremities, dryness of mouth, and pruritus. Okay, they get itching, especially of their nose. Okay, so when you see that, don't be surprised. You'll see that a lot in the operating room. People start scratching their nose a lot. It's from the narcotic, and it also can be from the benzodiazepines. Can also do something similar to that. If you look at the way the structure of morphine is, it's actually a fairly complex molecule. It has a lot of major groups. It's got alcohols, it's got amines, it's got phenols and ethers. It's got a lot of components to it. Now, analgesia is more effective when morphine is given before the painful stimulus I was telling you before. It's really better for dull, continuous pain. It's not very effective in very sharp pain. And so it's really, so if somebody has colicky pain, morphine's great. But if somebody has like a bad incisional pain, morphine may not work as well with it. Morphine is also very good for visceral pain as well as skeletal muscle or joint pain. If you don't have pain and you take morphine, you may actually become dysphoric, and it may actually cause a problem for you. So these agents really should be used only when you're having pain. Morphine pharmacokinetics, the absorption is not reliable, which I was talking about because the acidity breaks down the morphine. It's well absorbed after IM administration. Okay, so the onset is actually between 15 to 30 minutes. I showed it peaks in about 45 to 90 minutes. So that's one of the downsides of IM medications. You have to know this. If you want to give IM medications to somebody, the danger is if you're giving IV medications at the same time, let's say you're giving somebody fentanyl, and fentanyl works very quickly, and then you decide that you're going to give the IM injection 10 minutes beforehand. Well, what happens is they peak together at that point, and this person then develops apnea. And so that's a pretty dangerous thing about IM medications. A lot of people think that they're just depot drugs. You just give them, and everything will be fine. And I can add all the narcotics I want on top of that. Well, there's difference in absorption rates when you give it IM. Some people's muscles are more blood supply, so it absorbs faster. Some people are cold, and they're not really sending a lot of blood to the skeletal muscle, so the actual uptake is actually pretty slow. So IM injections are unpredictable, and I'm not a real fan of it. Now, I've seen, when I first started, we switched almost within about 2 years of me starting, we switched it to everything IV, and nothing was given IM before. It had worked in the early 80s in medicine. Everybody would get preoperative IM shots. So the patients that were coming to the OR would get atropine, and they would get morphine IM. Everybody. Okay? And then what they'd do is they'd go in the operating room, they'd put them to sleep, use a volatile anesthetic, and guess what they'd use for narcotics in the operating room? They wouldn't give anything. They wouldn't need to. The stuff would just sort of come in right in the middle of the case, and it'd be perfect. So by the time you're finished the case, you shut off your volatile anesthetic, the person would wake up comfortable, and you'd be done. Now, the reason they use atropine is because it's an anti-sialog, because it prevents you from getting the increased secretions. Now, why is this important for you to know? Because you don't do this anymore, right? So who cares? Well, because patients come from the emergency room. Patients that are in the emergency room are having a lot of pain. That's why they're coming in urgently to the operating room. So what do the emergency room physicians and nurses do there? They will give IV medications, or some of the old-timer ER doctors will give you an IM shot. And you got to pay attention to that. If you decide that you're going to give narcotics after you've given somebody IM Dilaudid or IM morphine, and you put them to sleep and you give them a little bit of fentanyl, just a little bit, like 50 mics or 100 mics, and it's like you think that's not going to be a big effect. By the time you're finished the case, the person won't breathe. And you're sitting there like, what the hell happened? And you go find out, sure enough, the person was given IM morphine 15 minutes before they left the OR. They left to go to the OR, and you put them in the operating room, put them to sleep, and you were still having the peak effect at 45 to 90 minutes into it. So IM medications are really treacherous. And how fast do people get discharged out of the PACU? 45 minutes. So look when it's peaking, when the person's down on the floor. And that's when they get apneic and die, because now they're no longer on monitors and nobody's watching them anymore. So I'm not a real fan of IM medications. If you want to give IM medications before you start the case, I don't have much of a problem with that, because by the time it peaks, you're going to be just finishing up the case and everything will be fine. Okay? But I'm not a fan at the end of the case to be giving IM injections of anything, because you can get burned. Okay? Because you have to know the pharmacokinetics of this. Now, for the IV route, the onset's fairly rapid. The peak effect is delayed by 15 to 30 minutes, and the CSF concentration peaks around 15 to 30 minutes. And it decays pretty quickly. So in other words, if you give morphine to somebody, don't expect that the peak effect is immediate. A lot of people get fooled by that. Okay? Fentanyl, on the other hand, which is why we use it so often, I should later, it's almost immediate. When you give that drug, it kicks up and it hits it very fast. And in 15 minutes, it goes down quickly. That's beneficial to us, because that way we can redose it, or if we gave too much, we can sit back and just let it wear off. Morphine, on the other hand, is not that way. Morphine, once it gets in you, it stays in there with you because it's water soluble. Okay? It does not want to come out, okay, once it binds. Now, what you're looking at when you actually see it says at peak CSF concentration, the actual percentage of morphine crossing into the CSF is actually fairly low. It only accounts for about 17% of what you inject. So the rest of the medication is going into your peripheral sites and circulating your blood, but not getting into your brain. Okay? And one of the things that you want to know is that in the early, I think, 90s, when fentanyl finally got out in the street, okay, a lot of people died very quickly because people weren't used to that effect. That morphine, when you inject it into yourself and you're an addict, it takes a while for it to kick in. Versus fentanyl was so immediate, okay, and people were hitting it too hard that the people would go apneic and not wake up, and of course die. So, morphine can also be used aerosolized. It's also very good for dyspnea, for patients with lung cancer and pleural effusions. You can actually put morphine in 5 milligrams of normal saline, and 5 milligrams in 4.5 cc's of normal saline, and then give it aerosolized, and the person will stop having the dyspnea. So there's some kind of opiate receptors in the lungs that help suppress this mechanism. The plasma morphine levels do not closely correlate to effect because it's really the brain that's what matters. So your plasma concentrations can be very high, and your CSF concentrations are not high enough to have the effect. CSF morphine concentrations peak in about 15 to 30 minutes, so that's what the important is of the effect in the brain. And analgesic and respiratory depressant do not occur during the initial high plasma concentrations. Because what did I just tell you? The drug doesn't get into the brain. You know there's high plasma concentrations. A very small percentage of it. Now, why is it taking so long to get in? Is because it's water soluble. How it gets through the blood-brain barrier is that it overwhelms the system and finally pushes through. Not like the lipid agents. The lipid agents just cross over like it's not even there. There's no blood-brain barrier. So the effects are very, very rapid, versus these are very slow. The volume of distribution is very small because you don't have a large lipid solubility. Okay? And if you look at how much it gains access, they've actually put down to less than 0.1%. I tend to disagree with that, but that's what the book says. I've read other places where it says 17% into their brain. That seems more likely to me, but anyways. The reasons for the poor penetration of CSF include poor lipid solubility, which is number one reason. The other thing is it's highly ionized at physiologic pH, so that makes it not cross the blood-brain barrier. It also has extensive protein binding, and it rapidly conjugates and is metabolized, which I'm going to show you next. Now, one of the things that you can change is that you can change the alkalization of your pH by hyperventilating. If you hyperventilate and cause respiratory alkalosis, you increase the non-ionized fraction of the drug, and as a consequence, you increase the passage into the CSF, and you get a much more rapid response. And that's, you can actually see that when you give people that are panicked and are freaking out, and you give them morphine, all of a sudden you get a very rapid effect that you don't expect. Now, where you also see it is on the other extreme, when the person becomes hypoventilating, and they develop a respiratory acidosis. In this case, they're going to actually ionize the molecule more, right? So that should stop it. But what they're doing is when they're hypoventilating, they're becoming hypercarbic, and hypercarbia increasing cerebral blood flow by tremendous amounts. That increase in cerebral blood flow will actually increase the CSF concentrations as a consequence. So high blood flow is actually more important than ionization. The other thing that when you give an initial dose of morphine, IV, it usually doesn't have significant first pass effect to the lungs. It accumulates rapidly in the kidneys, liver, and skeletal muscle over time. Now, how is morphine metabolized? That's actually pretty important. Morphine is broken down by demethylation, okay, and conjugation with glucuronic acid in the liver and extrahepatic sites. The actual kidneys actually have a very important component to this as well. The actual water-soluble glucuronides are removed by the kidney. There's elimination. But the kidney is also responsible for this metabolism as well. Now, 90% of the metabolites of morphine is morphine 6-gluconate. Okay? Sorry, morphine 3-gluconate, glucuronide. It's pharmacologically inactive. Okay? So you don't have to worry about that one. That one the body's going to get rid of without any problems. But on the other hand, about 10% of the metabolites convert into what's called morphine 6-glucuronide. That is actually the active one. It's pharmacologically more potent than morphine and actually has a longer duration of action than morphine. What ends up happening is that your kidneys have to be responsible to remove the morphine 6-glucuronide. Okay, it's not water soluble. Okay? Now, the other thing that will inhibit, will cause an increase in morphine effects are patients that are on MAO inhibitors, because they inhibit the formation of glucuronide metabolites, and it leads to an exaggerated effect. Renal effects are very important in the sense that metabolize the medications tremendously. They're so important that a patient that's getting a liver transplant and has the liver being removed in what's called the anhepatic phase. The anhepatic is without liver. That's when they actually take the liver out. And when they do that, the clearance of morphine is still unchanged. So kidney actually is metabolizing a lot of the stuff still. So it does not need the liver. The more of the effects of having problems with morphine is if you have renal failure, because you can't get rid of the morphine 6-glucuronide. So renal failure does cause a problem. So renal elevation is a single contribution to a total elimination. Small amounts of unchanged drugs are found in the urine. Majority is the morphine glucuronides, the 3 and the 6. So if you have patients with renal failure, that leads to accumulation of the metabolites and may lead to unexpected respiratory depression. And renal failure shows that higher plasma concentrations reflecting a smaller volume distribution in individuals. Your morphine elimination time decreases in the plasma concentration. Morphine at initial distribution is principally due to metabolism. So this is one of those agents that's water soluble, gets into your bloodstream, and then it gets added a glucuronide component, which makes it even more water soluble. 90% of it is no longer going to do anything, but the 10% will stick around unless your kidney is able to remove it. But because it's so water soluble, it's not going to go into your fat, so it's not going to be prolonged of action for that reason. It's basically dependent on metabolism. If you have people that are limited in their metabolism, which is the elderly or young kids where they don't have the P450 really cranked, then you'll have these people have a prolonged effect, and you have a delayed clearance. Clearance of morphine is decreased in the first 4 days of life, making the neonates more sensitive to respiratory depression of morphine. So you got to be aware of that. Not that we give it very much to neonates, but if you end up doing an anesthetic case and you add morphine to them, I wouldn't recommend it. I think you should be better off with something that's a lipid soluble agent like fentanyl. The cardiovascular side effects of morphine is that under normal circumstances, if you're supine and you're normal bulimic, there's really very little effect. Okay? It causes no real direct myocardial depression or hypotension, even with high doses. On the other hand, if you're standing, okay, even if you're normal bulimic, it can cause hypotension and syncope. Because what morphine basically does is it affects the sympathetic nervous system. And this is really important for you to understand about narcotics. All narcotics do this. They all suppress the ALS, the lateral section sending sympathetic information out. If you suppress it in somebody, let's say somebody who's really, sympathetically driven from a major traumatic injury, I know what they just said to you, right? It says it causes no direct myocardial depression or hypotension. And that's true for the normal individual lying flat. Because when you're lying flat, what happens to your sympathetics? They're kind of just happy leaving things alone. But as soon as you stand up, my body's got a vasoconstrictor in my legs to keep the blood flow going to my brain. So if I give that person narcotic, the sympathetics will basically shut down, the person will vasodilate, and then the blood pressure will drop. It's not that the narcotic is a direct myocardial depressant. It's not that the actual medication causes vasodilation. It doesn't do that. But it does affect the autonomics. It does suppress the autonomic nervous system. And that's where they're going to catch you on the test. They're going to say to you, so does morphine cause a hypotension in a person who's normal? The answer is no. Will morphine cause hypotension in somebody who's in shock? Absolutely. Okay? And they found that out the hard way in World War II. They actually were giving people narcotics who were already hypotensive and shock. And guess what? They got more hypotensive and then died. Okay? Which is okay because they're going to die anyways most of the time. You might as well keep them comfortable, right? I mean, there's got to be some things of a balance sometimes. Now, it's a decreased vasomotor tone leading to decreases in preload, cardiac output, and blood pressure as a consequence. So it's an indirect effect. So they tell you, well, what's the direct effects of morphine? There is none. It doesn't cause bradycardia. It doesn't normally cause hypotension. But indirectly, it suppresses sympathetics. A decrease in blood pressure can be induced by bradycardia or histamine release. Now, bradycardia effect is highly variable. You really have to give a lot of morphine to somebody to cause bradycardia. Okay? Or the person could be in shock. It also has an increase in vagal activity and has some direct effects on the SA and AV node. Giving pre-op opiates prior to induction tends to slow the heart rate during exposure to volatile anesthetics with or without surgical stimulation. We do know that to be pretty true. Sometimes we'll actually add things like Pavulon to offset that effect, especially when we're using fentanyl, because fentanyl causes immense amounts of bradycardia. Now, morphine, the reason that we don't use morphine like we used to is because of this problem. Morphine causes histamine release, and quite a bit of it, okay? And nothing more impressive than having somebody get histamine release on you and get severely hypotensive. And it doesn't take much. It takes only 1 milligram per kilogram over a 10-minute period to get this histamine release. And these are a significant drop in blood pressure and SVR. What you can do to stop this is give it slower and maintain the patient flat and keep the patient well hydrated, and there's very little effect. But not all patients respond appropriately. Sometimes they'd be very profoundly hypotensive. Sometimes we used to give pre-treatment with H1, H2 blockers. It doesn't prevent the release of histamine, but it does seem to prevent the changes in blood pressure and SVR because you're binding to the receptors, so you don't have the histamine binding to the sites. So it kind of worked. So we'd give Pepsid to these people ahead of time. It does not sensitize the heart to catecholamines, which is good. Commonly given with volatile anesthetics, basically to complete amnesia for painful surgical stimulus. Now, I don't like that sentence because what it basically tries to imply to you that it causes amnesia. What it does is it basically tells a person, it shuts down their opiate receptors that they don't feel it as being painful. People will still tell you, well, I got cut, but I just don't remember it hurting. But they still remember. Morphine or narcotics, even in high amounts, does not ensure that the person is truly amnestic. They may be amnestic to pain, but they're still not amnestic. You know that you're being cut on. Okay, I've had two people that have had awareness. One was a trauma patient. The other one that I had was a patient coming out of open heart surgery. And the person, we caught it pretty quickly and gave him more stuff and basically put him back down. But he says he remembers coming out of the coming off bypass, and we were talking. He could hear us talking, and I asked him, I said, did it hurt at all? He said, nope. It was just irritating that you guys were talking. It's like, okay. What were we talking about? He says, the surgeon was talking about golf. I really hate golf. If you'd been talking about girls, I'd have been happy, he said. I said, okay. He said, you were having open heart surgery. We're not going to talk about girls, okay? All right. So, and he had his chest wide open. He's got cannulas in the aorta. And the only thing he hated was to talk about golf. I could tend to agree, but it worked out okay for him. He didn't seem to mind. Didn't get any post-traumatic stress disorder or anything like that. We just talked to him about it, and he cleared pretty quickly. But we learned that day that you want to make sure that you give more adverse ed before you're coming off. That's when people have emergence. Because a warming is what wakes up the brain again. That's why we start everybody on Diprovan now as they emerge from the anesthetic, as they emerge from the bypass. So we don't have that problem anymore. So the only things that you also have, a combination of opiate with nitrous oxide results in cardiac depression. And you'll see the same thing with opiates and benzodiazepines mixed together. They're synergistic. Ventilation. Narcotics are very specific. It's dose dependent. If I give you more, the more respiratory depression I get. If I give so much, I will develop apnea. The person will stop breathing. Now, what's really cool about narcotics is they work in a certain way. When you increase the depth of anesthesia by volatile, the respiratory rate keeps increasing, and the tidal volumes get smaller and smaller. Okay? So overall minute ventilation drops with volatile anesthetics. But narcotics work kind of differently. Narcotics work by slowing your respiratory rate down and increasing your tidal volume. So it actually is supportive of breathing, but the downside of it is that your minute ventilation overall is down, because the rate is actually more important than the tidal volume increase that you get. But you can actually, if you know how narcotics work, you don't have to be afraid of them, because you can give a narcotic and you should expect to have a dose-dependent response. If I want somebody, let's say somebody's breathing 40 times a minute, that means he's in a lot of pain, usually. And as I need to drop off the volatile anesthetic and wake the person up. At that point, I'm going to start adding narcotics. And I can use morphine, I can use fentanyl, whatever I want to use. But I got to remember one thing. Morphine takes 15 minutes to peak IV. Fentanyl peaks in about 6 minutes. So I got to be a little bit more careful with morphine. So when you give morphine, just wait a few more seconds, see how that effect hits you. And if you give it too much, and this is what used to happen in the old days, we'd give too much morphine at the end, and they would actually go apneic. And then you were screwed. And you go like, oh, come on. And because now the peak effect's going to last for how long? 45 minutes. You're going to be 45 minutes in the room before the guy will breathe. Talk about a real bummer. Okay? So with fentanyl, on the other hand, if you make a mistake, the peak effect is gone in around 15 minutes. In 15 minutes, it starts dropping back down because it redistributes because it's so highly lipid soluble. So it's more forgiving. So if you're going to add a narcotic at the end of a case, if you're learning how to give narcotics to people so you make them wake up comfortably, then use fentanyl because it is more forgiving. Morphine is great if you want a longer acting action. And what I do personally is when I do OB C-sections is I put somebody to sleep if I have to. We get them intubated, secured. They start them on volatile anesthetics, go to 1 MAC or less. And as soon as the baby's out, I take a stick of morphine, which is 10 milligrams, and go, one shot. And I'm done. Okay? Because the surgeon's going to take 30 minutes to be done from that point usually. So when I give it, in 15 minutes it's peaking, and in 30 minutes the person is stabilized, and at the end, the morphine's starting to taper off, and then by that point, breathing again, and you get them extubated, they're super comfortable. And it works really well. Okay? So when at first I saw somebody do that, I said, you're going to cause an overdose, and I thought about it. I said, you know what, I need to tell you guys that this works. It works really effectively. 10 milligrams in high doses like that, if somebody's intubated and doing it in the middle of the case, is actually pretty smart. Now, are you going to get the histamine release? No. Not with 10 milligrams of morphine. The amount of morphine that I'm talking about, histamine release, you're giving 50 to 100 milligrams of morphine. That's how much we used to give for open hearts. 50 to 100 milligrams of IV morphine. 10 ampules. Okay? We used to give 100 cc's of fentanyl. I used to think this is ridiculous, and it was, but at least you don't have to do that anymore. All right, so what you do see is overall, if you get too much of a dose, you get into the apnea. The other thing that appears that patients asleep and then not breathing, which is kind of weird, but if you tell the patient to breathe, they will breathe, but it doesn't cause amnesia. So it's not an amnestic. It's only an analgesic. Okay? It's basically a primary agonist effect on the mu2 receptor. That's how this actually works. The other thing that morphine will do is, and all the narcotics will do, is it suppresses the CO2 response curves. So you get a decreased responsiveness to an increase in carbon dioxide, so that diminished sensitivity to carbon dioxide, which causes right shift, which is what this does. Okay? So this is a person who's awake. Normal CO2 is around 40. So their minute ventilation is around 5 liters per minute. When the person gets more and more narcotic, minute ventilation will drop off, and their CO2 will begin to rise. It can be offset by things like surgical pain. So when you give narcotics to somebody and then the surgeon makes an incision, some of the CO2 response curve will shift back and the person will be faster. And we actually use that to our advantage when we're putting an LMA in somebody. And the other thing that will reverse this will be metabolic acidosis. One of the things that also will reverse this effect, if you give the person, of course, Narcan, but also if you give the person physostigmine, which increases acetylcholine levels, you can actually reverse this effect as well. The reason we don't like doing that is it can cause some problems, so we'll talk a little later on about what physostigmine can do. Pulmonary effects is a dose-dependent depression and ciliary activity. It also increases airway resistance by causing bronchial smooth muscle contraction, an increase in histamine release. Most narcotics are suppressors of cough, codeine being much more effective than morphine, and that's what it's used for most. I think I'll stop here and we'll start back up. Give you guys a 10-minute break.